Now, all three papers are open for discussion. Um, this, yes, Professor Cecchi.
Yes. Well, all three papers were very good, and I was quite interested by Susie quoted data. Are you here? Okay. And well, I believe that when you study epidemiologically, this kind of disease, you also have to take care of what happens in the hospital. How many cases of rheumatic fever were, if you detected them, were recorded in the hospital in Aswan at the same time?
Because we are a heart center, they don't come to us. They go to the general hospital, which is next door, but we don't have any data about rheumatic fever itself. The acute rheumatic fever we don't see. We only see the rheumatic heart disease. So even when we went to the schools, we didn't detect any acute rheumatic fever or rheumatic fever patients or cases. And even from all the children we have screened and diagnosed with rheumatic heart disease, none of them had history of rheumatic fever or did not even recognize the symptoms. So they sometimes said, yes, I used to have tonsillitis, but none of them had arthritis or anything else. So actually rheumatic fever we don't see.
But in your study, in your thesis,
Yes.
you did have a study in Cairo from the rheumatic fever prevention clinic. Do you want to comment on that?
Yes, of course. In Cairo, I went to the National Heart Institute and to the penicillin clinic because there is a penicillin clinic where patients with history of rheumatic fever or rheumatic heart disease go every month for their penicillin prophylaxis, and we did echoes to see how many of them had developed rheumatic heart disease since they were diagnosed with rheumatic fever. In that study group, they were much older. They were started from 15 to 45 years old. But they had more often the rheumatic fever history, and they recognized the arthritis, the recurrences, and even they mentioned that whenever they were not compliant to the prophylaxis, that they had again the same symptoms they had before with the arthritis and the tonsillitis.
I mean, the study you did, is a mine. I mean, you have an enormous amount of data, I believe. And you have done echocardiogram in each school children. I mean, and there were more than 3,000 as far as I remember. So how many additional diseases did you find, congenital or cardiomyopathies or whatever?
Yes, we found 3 children with congenital heart disease. We had 1 partial AV canal and 2 ASDs. So that was for a plus. And actually 2 of them were already have been operated on at Aswan Heart Center.
No cardiomyopathy?
No cardiomyopathy.
Bicuspid?
You wasn't looking very hard for bicuspid valve. Is that true,
Yes,
Susie?
that's true. Yes, but we did look at aorta.
You did look at the aorta, but concentrating on regurgitation rather than or bicuspid and phenotype. Questions from the floor? Yes.
I'm really disturbed by this penicillin, this logo. I mean, this logo implies only secondary prevention. I think that rheumatic fever and rheumatic heart disease is a disease of low socioeconomic and low hygienic, and the primary prevention is really very easy by just increasing the awareness of the population. If you go to the schools and teach the children how to wash their hands before eating and after leaving, after playing in the playgrounds, and better aeration for the schools and less crowdness, I think we can solve a big part of this problem. I know I've been working in Cairo University for a long time. I've noted that rheumatic heart disease has become less stronger, causes less complications than before. When I started working in the...
So the campaign for...
primary prevention rather than waiting for the patient.
I think it's easier said than done, and yes, you have to raise the income as well as the hygiene, as well as everything. That will take a long time. And I'm not a defeatist, but I think there should be a multifactorial attack, and you're actually doing just that, and as you highlighted. As I take this opportunity about primary prevention to ask Professor Bono, who talked about the Bongani Mayosi studies showing that from Cuba, and I don't know which other country, that Costa Rica, that the primary prevention with penicillin appeared to be effective, because I'm conscious of a trial which was funded by the US and conducted in New Zealand, where the results were negative, where they spent a massive amount of money on treating throat infection, and with dismal results with regard to prevention of rheumatic heart disease. You want to comment on that?
Well, I think I share your pessimism about that as an approach. First of all, I mean, those were data, but I'm not sure how complete the analysis was, and whether there was underestimate of the true prevalence of disease, and whether that's sustainable with time or not. And these were small countries with relatively captive population within the healthcare system as it exists, at least in Cuba, Costa Rica, and then to extrapolate that to larger countries, rural populations, mountainous regions, little access to healthcare, I think could be quite difficult to see that this is the solution. Although obviously it should be part of the program, but I'm not sure it's the active part of the program.
Thank you. So the effective therapy, you mentioned it when we were sitting, and Susie has mentioned it in her thesis repeatedly, is the development of a vaccine. Can I ask, what are the difficulties of developing a vaccine, Susie?
Yes. It's actually mainly the strain itself, because the vaccine is targeting a strain, but whenever we look at geographical differences, we see different strains in different areas. Actually, we have been trying to indicate, to diagnose which strain is most common in Egypt. Unfortunately, we haven't been able to reach that phase. We have collected samples, throat swabs, and
can you very quickly tell us the avenues of looking at the M protein, and is it molecular, and the octapeptides and
yes,
all that? So there are avenues, but they are different in different countries, and therefore developing a single vaccine which will be effective all over the world is a challenge, not impossible, but a challenge. Sorry, I'll here go to Dr. Al-Mutarrab. I mean, this is incredible data, or we really thank you for all your efforts there. Obviously, there are so many things to do in Yemen, and that should be addressed. Do you want to prioritize? You told us so many things we should be doing, or which should be done, but what's number one priority? Is it the screening? Is it the secondary prevention? Is it the surgery? Or a combination of all of the above?
First of all, I'd like to just answer him. We are following the WHO guidelines. You have to give injection penicillin with every throat infection with streptococcus, and there is now a rapid detection for streptococcal, where if it is positive, just give an injection penicillin with every throat. Even if it is virus in Yemen, we recommend to give the injection with every throat, and if the throat infection or tonsillitis repeated for 4 times a year, you have to remove the tonsils. In Yemen, I would prefer to start by 2 steps. One, a national center for rheumatic heart disease in the capital to pool the data and to train the people. And the second one, massive and continuous awareness in the society and policymakers.
What about secondary prevention? I take your point, and Susie also talked about that, or found that the parents try to protect the children from this horrible injection. And I'm reminded by Professor Sidi from Paris, who apparently he tells the story of asking a child in sub-Saharan Africa, what do you want to do when you grow up? And he said, when I grow up, I want to give up these horrible injections in my bottom. So that is all what he aspired to, is to stop these dreadful injections. However, that's a perception, and your one injection for a healthy heart is a wonderful thing.
I just would like to comment on our, in regards to our colleague, Dr. Ahmed al-Mutarrif, whom I worked with for the past 8 to 10 years. He's a big fighter, so he has been, I didn't know he has been fighting rheumatic heart disease. He has been fighting qat chewing in Yemen. Yeah, and he has published actually in qat more than anybody else in the world. And he happened to be working in Al Thawra Hospital, which in English, the Revolution Hospital. A fighter and working in a Revolution Hospital.
Thank you very much.
May I ask a question to the experts, because I don't consider myself one. So we still, Dr. Al-Matrab and I were talking earlier, that we still see rheumatic heart disease in the United States. It's rare, but when it manifests itself, it's usually a 65 or 75-year-old woman. It's not an 18-year-old. So is this a different strain, or is it a combination of the strain and the socioeconomic status that these people come from, or is it, do we know?
This is the
I think it's a combination of both. It is a different strain, different rheumatogenicy, and it is a different genetic profile for the patient. That's why some patients develop at 18 years old, while others develop much later. So actually, it's a multi-functional thing.
I think there was a study, I mean, Susie, you reported that in your thesis about rheumatogenicity of the organisms. And this has been a difficult subject because people looked at the M protein and were looking at rheumatogenicity by serology. And then came sequencing with molecular biology. And the sequencing yielded very, very interesting points that it is not the homology to beta-myosin in the heart, because the cardiomyocytes don't get affected. It is actually something to do with an octapeptide which combines with a similar sequence on collagen 4, and there is a lead there, collagen 4, and that produces an autoantigen which produces an antibody, and that this could then affect the valves, and not only the valves, because collagen 4 is in the basement membrane of many organs in the endothelium, and therefore that can explain why you get chorea, lung affection, kidney disease, all things. But what it does not explain, why does the valves have chronic and all the other things disappear? There has to be an explanation, but also it will give some explanation to why rheumatogenic can attack a developed, hygienic, rich, so nobody is immune. So watch it, because this disease can affect you if you get the rheumatogenic strain. But equally, once you find out what is the rheumatogenic strain, then you can devise both diagnostic tests, simple, by biomarkers, as well as an effective vaccine, something which we have to work for. Any questions? Yes, sir.
Thank you all for the very nice presentations. Now, I'm trying to figure out in my mind, there's clearly a decline mortality of cardiovascular disease, for example, in the developed world. There is even recent trend to lower ST elevation MIs across the Atlantic in Europe. And I'm coming now to rheumatic fever. Now, apart from Costa Rica and Cuba, which you showed, we know, granted, that the incidence and the prevalence is very high in the developed world, but is it increasing or is it decreasing? Is there consistent data? This is a question I've been trying to figure out in WHO reports, and the report you mentioned of 168 pages, and I can't figure out from all these. There's a lot being written, but I want to come with one conclusion: is it increasing or is it decreasing? And can I ask the esteemed opinions whether it is increasing or from your readings, or it's decreasing?
Definitely it is not decreasing. I think it is increasing with the increasing of the population, and the situation is still the same as it is. We don't have accurate data, but we might know. If we conduct a nation surveillance, and after a while we repeated this surveillance, we might know if it is increasing or decreasing. But I don't think it is increasing from our, it is decreasing from our experience. We are seeing more patient and more patient.
Well, actually, I think that the lack of systematic echocardiographic surveys does show the need for more research, because we don't have any previous data. Like, our study is the first study in the whole area, so we can't compare with anything else. So actually we can look forward and do more systematic studies, and then
in Yemen as well.
Yeah.
Yes,
So due to the lack of the research, we can say anything about the past.
Could I also address the first part of your question,
Yes,
about
please.
whether we actually have a decline in cardiovascular disease, in mortality? That's age-adjusted data. And so if you do age-adjusted analysis, there's a decline. This is what one needs to compare 1990 versus 1940, or US versus other countries. If you actually look at mortality, total body deaths, it's flat. And it's likely to go up in my country with time, because of the new risk factors we have with obesity, diabetes, and so forth. Because we have a larger population and an older population. So when you do the age-adjusted analysis, it looks like a decline, but with a larger population and an older population, it's actually flat.
Yeah. Obviously, with the very welcomed introduction to echocardiography into the screening, this is a complicated matter, because before 10 years that wasn't there. So it becomes 10, 15 years, it wasn't there as consistent in the world. And therefore it becomes very difficult to compare 20 years ago with more use of echocardiography today. And I don't know if we will ever know the answer. I don't know.
Can I ask one question? For the second prevention for rheumatic fever, now I haven't seen a lot of patients, but I'm trying to extrapolate from other data. There have been a lot of revisions and guidelines how to treat patients. An example of that, infective endocarditis, we used to treat them in a way, and that has changed recently. Has there been any change? Has there been any evidence-based studies, rheumatic fever prevention, second prevention? Do we need to do that, or we just rely on the previous studies? Do we need to do some sort of newer protocol that will make it easier for individuals to use, or we just rely on the old regimen that I don't know for how long has been there, and what's the basis of it?
Well, actually, in the beginning it was a 4-week schedule, and then there were studies where it was shown that a 2 weeks or 3-week schedule in high endemic areas was a better prophylaxis rate for the patients. What we have been trying to do is to record the compliance and the amount of injections and the time period of the injections, and then look at the echo, see if there is any difference between the patients that are compatible or that do take the penicillin on time and the others that do not. So we can look at the best penicillin schedule, or the effect of the penicillin schedule on the valvular affection itself.
This is an excellent question, because while we all agree that secondary prevention is effective, it certainly is not 100% effective, because you still get a recurrence of disease. It does reduce the incidence, and both in Susie's studies and other studies, if you look at the valves which are excised in patients who have been on penicillin prophylaxis and are thought to have no activity. The valve is full, not exactly full, but anyway, has a lot of immune response with different types of cells, and some of these pictures are there in Susie's thesis for those who want to see. So it's not effective. We really need the vaccine very, very badly while we're waiting for the fighting poverty everywhere and hygiene and everything else. We're not going to raise the standards just with a magic wand. Vaccine is the way to go, I think, anyway. Any more questions? One more before we come to the final session. Where do we go from here? Sorry, madam. Yes.
Cases was diagnosed as a possible rheumatic disease, or they are diagnosed with rheumatic disease?
We had 70 children diagnosed with rheumatic heart disease, and we had an amount which was diagnosed as
But this
possible.
only depends on echo finding, right?
Yes.
But
What do you
to
mean?
diagnose with rheumatic disease, the patient has to fulfill
No, that's the
the
rheumatic
criteria
fever.
of rheumatic fever
Yeah.
before you diagnose them with rheumatic carditis.
But if they have rheumatic valvular affection, we don't need
But
the.
some echo finding, when we have mitral valve prolapse, thickened mitral valve, connected due to connective tissue disease or
That's
other.
why we have the fixed criteria, trying to avoid all the other diagnoses and
But
trying
it's
to be more
difficult
specific
by
for.
echo just to
Sorry?
diagnose them with rheumatic fever, because sometimes there is like a gray zone between an overlapping between the diagnosis.
But
right?
that's exactly why we have the definite rheumatic heart disease, which has definite features of the rheumatic heart disease, the dooming, the thickening, and the things that we don't see in other affection.
Well,
And I'm sorry, I mean, the specificity of the findings, there was a lot of agonizing with a group in Aswan, and we thought about it a lot with Susie, is what constitutes specific criteria for diagnosing rheumatic. I mean, like stenosis, mitral stenosis with thickening of the subvalvular region, nothing else will produce that except mitral stenosis. Thickening of the cusps. The group, the panel, when we were talking about it, insisted that it has to be, and I think you had it in your slide, 3 millimeters or more. Now, 3 or 4.
Three, actually.
Huh?
We've done even 4.
4. I mean, so it's really marked thickening. So you don't have that. And then we have structural and functional, and you must have combination. And the whole idea of the WHO and the recent World Federation, Heart Federation, is to get specific criteria and say this is indeed either definite mitral affection or possible mitral affection. The next question is, they are subclinical because clinically they seem to be all right. The next question is, what's going to happen to them? That's the critical question. And it might be that we are exaggerating, or Susie is, because if you get these patients, and she's doing that now as we speak, getting the same patients a year later and seeing what happened to them, how many developed more florid, and how many of the negative ones became positive. And she finds that some of the negative became positive. And indeed, some of the we thought was positive actually disappeared, especially the functional mitral regurgitation, even more than grade 2, with some structural, and it's come better. So you're quite right. We need to have specific criteria, and we need to understand the significance of that in the longer term.